Perfeito, professor. Então, voltando, retomando as nossas atividades depois do nosso coffee break, que foi super produtivo. A gente vai chamar agora a doutora Alexia Afonso Antunes Marcos. Ela faz parte do nosso programa de Jovens Lideranças Médicas e ela também está junto na UNIFESP, no Instituto da Visão do IPEPO, trabalhando pertinho do professor Rubens. Então, vamos iniciar esse módulo agora de uso de células-tronco, verdade ou mito. Alexia, por favor.
I will speak in English because of Michael. So first, I'd like to thank him to accept our invite. Dr. Michael Young is an associate professor of ophthalmology at Harvard Medical School, as a co-director of the Ocular Regenerative Medical Institute and director of Mind Gantz Center for Retina Degeneration. And also we have Dr. Rodrigo Branch. He's head of the retina sector of the São Paulo School of Medicine. And we will start the discussion with a 5-minute class, and then we will begin the question sections. So thank you again, Dr. Michael, and you are free to go. Thank you.
And I want to especially thank Michael Young for his presence here. I had the opportunity to stay at Michael's lab for 2 years to do my postdoc in 2010. And he's a really, really great guy and very special in science. He developed new techniques for stem cell development, especially in human retinal progenitor cells. And he has a huge experience in stem cell for retinal diseases.
Thank you very much. Good morning, everybody. It's a pleasure to talk to you today. So I have a couple of ways I could go. Now, I was presented with some questions. Caio, shall I proceed with the questions that were sent to me as an introduction and proceed from there?
Yes, yes.
Okay. May I share my screen?
Yes.
Okay, how's it? Can you see?
Yes, good.
Yes. Thank you.
So welcome everybody. Today I just have a couple of conflicts I want to discuss with you. I'm going to talk a little bit about one of the trials using retinal progenitor cells from Reneuron. I helped develop these cells and I'm a consultant to them. And we also have a startup, Cone Site Therapeutics, aimed at replacing cones in the retina with stem cells. And I'll talk a little bit about that as well. But I was presented with 7 really good questions that get to the heart of the matter of stem cells, truth or lies in the retina, at least. I'm going to talk specifically about the retina space today. So I thought I would just give some very brief answers to these questions. And of course, the devil is in the details. In our discussion today, we can go deeper into them one by one, perhaps. But the first question was, what type of stem cells are currently being studied? And the answer to that question is so many, from so many places. These include bone marrow-derived cells, mesenchymal stem cells, adipose-derived cells, and of course, my favorite, actual retinal cells that are being developed for replacing lost photoreceptors and retinal pigment epithelium, but as well as ganglion cells and other cell types in the retina. So the answer to that question is there are so many different cell types being studied, it's almost impossible to keep up with them. I did a little quick search today for stem cells and retina on clinicaltrials.gov, and the number that pops up is 93. And there's not 93 different cell types being discovered, being investigated, but it's close to that. And the next question that was posed to me was, what are the options?
Michael, let me ask you a question.
Yeah.
Which cell do you think is going to be the best cell type?
That's question number 4. So we'll get to that, Caio. We'll get to that in a moment. But the answer to this question is the same. there are many different applications. And if you look at these trials, there are dozens of different therapeutic windows that are being investigated. Anywhere from retinal ischemia to, of course, inherited retinal diseases, all the way up to complex diseases such as macular degeneration. And here we go. Caio, was question number 3. Sorry about that. Is a subtype of stem cells more suitable for fixing either the back of the eye or the front of the eye? The cornea and the ocular surface have very similar issues. But in one word, I would say the answer to that is retinal. That includes stem cell derived retinal neurons and retinal pigment epithelium. But I think, in my opinion, as a PhD, as a rat doctor, as my kids tell me, it's most important to focus in these early phases, I believe, at least for transformation into tissue on actual retinal neurons. And so there's been decades now of studies aimed at transdifferentiation and trying to turn other cell types into retinal neurons. And I would say most of these studies have failed. And so, there's an old joke about, why do you rob banks? They asked somebody once, and he said, that's where the money is. So if you want to go after a retinal cell, I think starting with a retinal population or a stem cell that can turn into retina is most important. And so this is a very different.
Michael, can you tell us more, because you developed the human retinal progenitor cells, and also you sold your patent to Regeneron. That's a company. Can you tell us more about that? How did you develop, and after that, how were the research with these cells? I think
so. I can tell you that it started about 20 years ago when I first got my lab at Harvard. So in those early days, before central nervous system stem cells were fully described or really known to exist, I must say, we were searching for a cell that could not only possess potency, that is the ability to turn into a retinal cell, but also the ability to proliferate and generate the type of cells that are needed for a clinical trial. So taking it from very interesting, but not terribly transformative studies in rodents into humans. So the key for us was figuring out how to grow human retinal stem cells and expand them. And that changed greatly with some of the early discoveries of other stem cells in the central nervous system, for instance, from the hippocampus, that led us to postulate that maybe in the retina there really are stem cells, or at least let's call them multipotent progenitor cells that can make rods and cones, maybe make ganglion cells, of course, make retinal pigment epithelial cells. We focused in on a rod-based progenitor cell from fetal retina and isolated and discovered about 15 years ago that if we grew those cells in low oxygen culture, we could indeed generate enough cells to mount a clinical trial. So that was a transformative event, figuring out how to proliferate these cells and make them into what could be a clinical product. And that led to an alliance, as you mentioned, with Regeneron, who now have a phase 2B clinical trial at Harvard and several other institutions. They've actually stepped outside the US to Oxford with Robert McLaren and are going to do some patients at Oxford upcoming. So yeah, this has been an experience that I've learned a lot from. And as we mount, what we'll call 2.0, our new work with cone site therapeutics aimed at generating cones for macular disease, such as cone dystrophies, and someday we hope macular degeneration. We've learned how to do this translational approach of going from rodent studies, large animal studies, into the human cell type, and then pushing them through all the phases of preclinical development and into the clinic. So I hope it doesn't take me 20 years this time, but I think we've learned a lot with this experience. And the reneuron cells still show great promise for retinitis pigmentosa, both in terms of preservation of vision, but maybe even vision restoration.
Yeah, yes, I think it's we have a lot of young people here, and I think it's a very, very nice example from translational medicine. Michael developed a stem cell methodology to isolate stem cell from the retina, fetal retina, in rodents first, and after that on human, and everything was experimental. And right now, those cells are used in a clinical trial. So as you can see, he did all this pathway since the lab and now to the clinic. So it is this amazing thing that you had all this pathway since the lab until the clinic. For us, I think it's amazing.
And don't forget, we had a very critical Brazilian phase to this work, from mouse to human, and that there were some really important pig studies that were done in Goiânia with Murilo Abud, one of my also former students, and the group in Goiânia, in which the first point to make is that it's really hard to study what a human cell is going to do in a patient by putting it into even a non-human primate. So we took a step backwards and isolated a pig stem cell from green pigs so we could follow them and transplanted under the retina of pig recipients. And this was funded by the Foundation Fighting Blindness and taken very seriously by the FDA. Even though this was not the clinical product, we demonstrated that it was equivalent to the human cells. And not only did we get at the mechanism of activity, and that is cell replacement, but we learned a great deal about immunosuppression protocols and dosage and cell delivery, all from doing a large group of studies in Goiânia with pigs into pigs. So we called this the analogous allograft study, and proved to be very important for getting us into patients. And all of the lessons we learned and the decisions that were made by Reneuron in this clinical trial and by Jason Commander, the PI of this trial at Harvard, proved to be correct. So just a little caveat that xenografts are hard and not terribly informative, in my opinion. And so taking a step backwards and looking at large animal models as allografts can be very instructive.
Yes, this study that Michael just mentioned, we did in Goiânia, here in Brazil. We did a big study here, and also with Murilo Abud, who was a postdoc at Michael's lab too. And we put these human cells, we did a subretinal transplantation in pigs. So it's what was done here in Brazil.
Very good. So the answer, if I turn back to this question, is simple first. So I mentioned that because there are relatively simple inherited retinal diseases that are a result of point mutations in a single cell type. And these are best for some of these early proof of principle, first-in-man trials. I think that's different when we move, and I should talk a little bit more about that. Again, I'm a neurobiologist by training. I like neurons, but I'm certainly appreciative that the leading candidates and the leading work being done in this space are retinal pigment epithelial cell transplantation. And so I think it's very important when looking at these types of trials to look also as I mentioned before, at both structure and function in terms of patient selection. And I'll put a plug in for some of the work taking place in Sao Paulo. I think it's very critical. One of the most important questions in the RPE space remains polymer or no polymer, substrate or no substrates, a simple injection of floating cells or an organized monolayer. And so I think just looking again at clinicaltrials.gov, it's clear that this trial going on in Sao Paulo is addressing this particular point. And there's, just like there are many different cell types out there for choosing your donor cell, with RPE, there are many different trials, all looking at something a little different. And principally that difference has to do with the substrate. So I think it's very important that we know, can these cells survive well as a monolayer? There's been some great evidence that's come out from regenerative patch technologies in California, Dennis Clegg's group, that have shown through a patient that's passed away that on a polymer scaffold, there can be good evidence both of improved visual acuity as well as a long-term survival. So I think the issue of substrate is very critical. And I just answered that question a little bit. There is evidence of improved visual acuity in some patients from a variety of the RPE-based trials. Just to turn our attention to photoreceptor transplantation, the two players in this space, again, are the cells that I developed with Reneuron and J-Site. So Reneuron is transplanting fetal-derived retinal progenitor cells under the retina. J-Site is transplanting a very similar cell type into the vitreous chamber. And so one can think of these as just simply as two mechanisms of action. Reneuron is trying to replace photoreceptors. J-Site is trying to preserve photoreceptors, both promising early data. It really is going to come down to the phase 3 trials, the pivotal phase 3 trials that are upcoming. And we'll find out if either of these mechanisms works. But the answer to that question, yes. There is bona fide evidence of visual acuity improvement, and you can call that either preservation from the fellow eye or actually de novo photoreceptors giving rise to new vision. And these are important questions that I think will be answered in the coming couple of years as these phase 3 trials play out.
Michael, I have a question, and I think Rodrigo might help with this question. Which place do you think is better? Do you think if you inject in the vitreous, the cells are able to migrate to underneath the retina and survive and differentiate, or do you think that the injection must be on subretinal space?
I think based upon, again, injecting hundreds and probably thousands of recipients over the years, it depends upon the cell type. So my experience with the retinal progenitor cell space is that injecting them into the vitreous is a really bad idea for lots of reasons. It may be possible that trophic factor delivery does indeed preserve and maybe even improve the function of existing photoreceptors. Many of you know more about the ellipsoid zone and the inner-outer segment junction and how that can be an indicator of photoreceptor health. So the idea would be that you're not replacing photoreceptors, but you're making the ones that are surviving work better. So not only helping their lifespan, preserving them, but improving their function by getting at this very important RPE photoreceptor microenvironment. And improving the outer elements of a photoreceptor can make it work better and can potentially improve visual acuity without de novo photoreceptors. Okay, so I think there's room, there's space in this area for preservation through vitreal injection. It's much less invasive. But if long-term vision restoration is your goal, then I believe subretinal space injections are required.
I think I agree, Michael. This is Rodrigo. That's what we saw when we have like reflow of cells to the vitreous cavity. All those cells, they tend to form into like clumps of matter in the internal limiting membrane. So they're not functional. They don't integrate anywhere. And there's another evidence that showed like very recently, they were trying to inject ganglion cells to treat glaucoma. They're trying to inject in the vitreous. And they saw that they never integrated into the retina when they injected in the vitreous. And by accident, a technician looks like he cut the internal limiting membrane in one of those animals. And in the side of the cut where there was no limiting membrane, that was the only site where those cells could like integrate. So if you're trying to do something maybe for inner retina, you're probably going to have to remove the ILM in patients. Yes. So those cells integrate. So that's something that we see like in the clinical trials, and maybe that's the case for humans. So.
I think that's entirely correct. I agree with that. Now, keep in mind, there have been some early rodent studies showing that transplantation into the vitreous with retinal ganglion subtypes can give rise to new ganglion cells, but the inner limiting membrane and the retina of rodents is very different than humans. And I know surgeons have talked about ILM peels as a sort of co-therapy with retinal ganglion cell injections, but I'll just say that there's been remarkable evidence, and we have been part of a team trying to address this with stem cells, ganglion cell transplantation. So Caio mentioned, we've been fortunate to connect with the Gilbert Foundation. Dan Gilbert is the founder of that. He owns the Cleveland Cavaliers basketball team, but also a mortgage company called Quicken Loans, a big mortgage company in the States. Very wealthy man, but his son is blinded by neurofibromatosis type 1. So this is an optic neuropathy, optic nerve gliomas, optic pathway gliomas form. And so there's a large group. We're working with Don Zach from Johns Hopkins and Jeff Goldberg from Stanford on trying to develop a stem cell therapy for glaucoma. But I think everybody on this Zoom realizes that this is not as simple as simply replacing rods and cones or retinal pigment epithelial. As difficult as those are, this is an order of magnitude greater, and it's obviously centers around retinal ganglion cells growing down the optic nerve and innervating the brain. So there have been studies where that exact thing does happen in rodents through transplantation, but we're probably a decade away from translation in glaucoma where we can actually restore vision with new ganglion cells. But it would have been science fiction a few years ago. And with some of these incredible developments in stem cell biology, also in polymer technology, where bridges can be used to rebuild optic nerves, these are things that are coming.
And Rodrigo, taking advantage of your surgical experience, Rodrigo did some subretinal stem cell transplantation. What do you think is going to be better? It's going to be better to do a vitrectomy and do a subretinal transplantation, or there are some people doing transscleral injection to suprachoroidal space? What do you think is going to be better?
That's something that we can only extrapolate from animal studies. What we saw, we tried suprachoroidal injection to try to be less invasive. What we saw in rodents and pigs is that when you go suprachoroidally, you break the blood-eye barrier, and sometimes the immune system can go there and reject those cells. There's phagocytosis of those cells in the subretinal space when we went suprachoroidally, because we break the choroid and some figurative elements from the blood came in and they destroyed those cells. So we moved on. We tried both in the beginning. We did that at USC with Dennis Clegg and Michael Mayan, and we moved to the subretinal injection with vitrectomy to try to avoid that. We saw that a lot of times in rodents and pigs. There was a lot of immune reaction when we break this blood-retinal barrier. So we try to move to the subretinal approach because of that. But that's just speculation, because we can't really tell that's going to happen in humans. You're going to have to, try to see it. But the rationale is that. The rationale is that trying to go subretinally through a vitrectomy may be inducing less immune reaction, less inflammation. But that's a question to be answered, I think. Michael, have any thoughts about it?
I mean, I think fundamentally this comes down to two things, I guess. The immunogenicity of the cell you're transplanting and the immune status of the microenvironment you're transplanting into. So I would say there's been, as you mentioned very, 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 very precisely, that we can only extrapolate from animal studies in some ways in this area until we do human surgery and human transplantation. So the fundamental question of the immune status of a degenerative microenvironment was an open question when these first-in-man stem cell therapies took place. And I think we can take heart in the fact that there appears to be some level of immune privilege in this compartment that is preserved even in the face of ongoing degeneration. I think that's borne out by some of these long-term survival studies that are coming out now in terms of the retinal pigment epithelial cell. I would call it a moderately immunogenic cell. It certainly has more immunogenicity and the ability to, for instance, present antigen than some of these, what I would call more pure retinal progenitor cell preparations that are being tested. So if these are even though it's neural crest derived, it's still a much more immunogenic cell than neurons. So the RPE cell can be rejected, certainly, more profoundly than a neuron. But we're seeing long-term survival in degenerative microenvironments. So I think that is very good news long-term. But disrupting the barrier with suprachoroidal space injections is something that we've been concerned about. We were involved in some device development for suprachoroidal space injections principally for viruses, but also applicable to cells. All of the work that we do in the laboratory in mice and in large animals involves not, of course, vitrectomies in rodents, but subretinal space injection. So that's been my preference. Go where the action is. Under the retina is where these cells can best do their thing.
I don't know if you have any question about the polymers and the substrate, but I think what's your idea? Because nowadays we have just injections of just the cells, but I think the efficiency of the transplantation with cells plus the scaffold must be much better. And Rodrigo also worked with Mark Humayan in development of the Parlane. So what are your ideas with the cells plus substrate injections?
So, go ahead.
No.
Please.
I opened my mic by accident. It's your time. Sorry.
So again, I would distinguish between RPE and neuronal transplantation in this space. My thoughts really point towards the need for a substrate in RPE cell transplantation. I think what that ideal polymer is, whether it is biodegradable or not, is the question. I do like the approach that Masayo Takahashi's group at the Riken began, first with ES and then IPS cells, in which a monolayer of RPE was grown that secretes its own basement membrane. And it would be an overstatement to call it a Brooks membrane, but it's the beginning of a Brooks membrane that can then be detached and through a device delivered. So it's let's call it a natural biodegradable substrate. And we contrast that with the group in London, Pete Coffey's group, with polyethylene, with the Parylene group in California, and some of these other approaches. I think the polarization of RPE are so important that delivering polarized cells is critical. And I think that will be borne out. But it's early days. It's going to take some pivotal phase 3 trials to really get at this question. For photoreceptor transplantation, let's summarize and just say, in the early first-in-man trials with Reneuron and then J-Site, it's clear that from a regulatory point of view, a simple cell suspension is preferred in first-in-man trials. But, Caio did a lot of work in the lab developing polycaprolactone as a substrate. We've published on PLGA, on PGF, polyglycerol sebacate, biorubber, and some other polymers in large and small animal trials. You get tremendous benefit in terms of cell survival by transplanting these cells with either a hydrogel solution or a hard polymer, shall we call it, with, polycaprolactone turned out to be very good in this regard in terms of cell survival and differentiation. But the surgery of a hard polymer scaffold for retinal degeneration is very challenging. Retinotomies are involved, forceps are involved. A 41 gauge DORC is very non-invasive compared to transplanting hard polymers. So I do believe that someday we will arrive at an ideal scaffold or polymeric delivery system for neuronal cells in the eye. But right now, there's good evidence, again, from Reneuron and J-Site's work, that transplanting these cells as a bolus in buffer can help improve vision in patients. So we're taking this stepwise and going slowly as we get more complex. And that includes technically and from a regulatory point of view.
Rodrigo, do you want to comment on this?
I agree. I think we saw a lot more cell survival and, of course, polarization. I'm talking mostly about RPE cells because that was what I worked for when we use a substrate. But the substrate, in the long term, that's what concerns us more. We don't have an ideal substrate. We went to biodegradable, but biodegradable is very hard. There's a lot of acid formation when it's degrading. So it's really damaging to the subretinal space, to the metabolic part of the retina in the subretinal space. So we're still, that's what I said. We're really extrapolating animal data, very short term. You have to remember, rats, rodents, they live we sacrifice them. The longest lived rodent we just left for 1 year, and pigs are 3 months. We can't do anything more than 3 months in a pig because the immune system rejects everything and becomes a mess. So we're extrapolating data from very short-term animal trials to humans, we're going to have to get, like, for example, a patient in his 60s, transplant something in the subretinal space and see what's happening 40 years in the future. So I think from the animal studies, we can see that the cell survives a lot better and they integrate better when they have a substrate, but we still don't have the ideal substrate. And in the long term, it's a very open question. We're going to have to see what's happening. New studies will probably address those questions, but it's an open field, really. It's really hard to, guess what's going to happen in the future. Maybe what we're discussing here is totally different in 10 years.
Yes, quite true.
Great. We can go on the questions.
So this was the last one that I was given. With CRISPR-Cas9, can we glimpse a future where we can take adult cells of a patient with ocular pathologies, transform the cell into an induced embryo, fix the genetic mutation and make young, healthy, non-immunogenic tissue, and replace diseased eye tissues in most age-related pathologies? And so I have two-word answers for this question. And the answer is yes, but. So even without CRISPR-Cas9, one can imagine this scenario. And maybe it's happened already, but it's clear that although we can make embryos from donor cells, and we can fix genetic mutations in those embryos, this is something that is a step too far at present. So if you replace the word embryo with organoid, however, then we start getting closer to what I would call the future of tissue engineering. So it's very difficult to create human embryos in the laboratory.
Michael, just to correct, I think it's not embryo, it's embryonic cell, embryonic stem cell probably here. You change the embryo for embryonic stem cell, IPS.
Yes, okay, so that, yes. So that's why I substituted the word organoid. Now, keep in mind, if we left this word embryo, there are still some groups out there. There's been some interesting work that's come out of China where they are, in fact, making embryos. So one caveat that I would make, and that's this non-immunogenic. Of course, immunogenetics is more complicated than we would like it to be. And even taking your own cells and making an organoid, making induced pluripotent stem cells, and modifying them with either CRISPR-Cas9 or an AAV vector, there are changes that take place in the genome, and your own cells are not necessarily your own cells anymore. So one can look at this from two sides. You could say that these cells are very non-immunogenetic and that these will survive very well, even if they are what we'll call a super donor allograft. But again, if we shift into the RPE space, there's no guarantees that even growing your own RPE, fixing them, and putting them back in is going to lead to permanent, non-rejecting survival. So that's the only caveat I would make. My experience in this space, and as it relates to the work in Japan with we'll call personalized medicine stem cells, and the work starting in DC with the group at NIH, it's very difficult to generate any kind of clinical trial, much less a therapy that can be widespread with this approach. So I would say we need to shift more into allografts and getting them to survive and not reject. And so that involves both cell delivery for survival and The use of super donors for your donor tissue someday is probably going to be very important in the RPE space.
Yes, because since just to people to know, when you work with iPS cell, that's induced pluripotent stem cell, you remove your own cell and de-differentiate this cell into a stem cell. So those cells, they will have also the genetic mutation of the disease. So before transplantation, you have to do a genetic engineering to change all this mutation in order not to have a cell that already have this kind of mutation, and it's going to degenerate after transplantation. So it's a really, really difficult step to get it.
Yes,
And
this is complicated. It takes a long time, and it's very expensive. And all of these things make it less translatable than, what's been described by the FDA group as the Holy Grail, which is a universal allograft. So off the shelf, you can think of this as kind of the way things take place on the ocular surface with corneal transplantation. So no tissue typing is done. Long-term immunosuppression is not needed, but local anti-inflammatory as needed is used. And that's what's happened with the Reneuron trial, in that there seems to be very little evidence of rejection, and just treating with anti-inflammatories locally seems to be enough to induce long-term benefit in the patient. So I see that as the future rather than a more personalized approach for cell transplantation.
And how is the trial right now, Michael? You told us that it's on a phase 2B trial with the HRPC cells.
Yes.
And what are the results right now?
So I would say the results thus far are very promising. So keep in mind that when cells like these are transplanted into the subretinal space, these retinal progenitor cells, they disappear. So we have no way of knowing that they're surviving long-term from any imaging modality. So all we're left with is the visual function. And of course, the most important thing in these early trials, adverse events. So we know that these cells are very safe. And the big worry, of course, with any stem cell that is still dividing is proliferation and tumor formation. And that hasn't happened in either the J-site or the Reneuron trial. So that's very promising. But the benefit in terms of visual acuity is complicated in that some patients have improved greatly, others less so. So I think this comes down to learning about patient selection to inform a pivotal phase 3 trial that we hope is upcoming. Again, I can say similar things about the trial with J-site. Some patients have improved quite significantly, many lines of vision, many letters of improvement, others less so. And so I would say, until we've performed those phase 3 trials, we don't know whether these cells work or not, but it's promising in these. And I say early days, we're 3 or 4 years into these trials, longer in some cases, but unfortunately that's reality. It takes years just to demonstrate safety. And so then you move on to patients that have a more likely chance of improvement, meaning they're not blind, as they say. They have some vision that can be augmented or even improved. And so, that's really what phase 3 is all about.
And how many patients have you included in this trial right now?
I don't have that number at the tip of my tip of my tongue. I know that J-Site has done a very large study. Their phase 2 has been quite large and involved a dose escalation into I think over 5 million cells are being transplanted into the vitreous in these patients now. So I think it's in the 30s for J-Site, and I think Reneuron is in the 20. Over 20 patients have been transplanted thus far. But I'll get back to you on that, Kyle. You can share what those numbers are. But again, we're in both J-Site and Reneuron, we're in advanced phase 2. So a phase 1, 2A trial progressing to a 2B. The hope is that it's going to be a breakthrough and you're going to go straight into phase 3. But in both cases, it was decided a 2B was required. And so that's where we are now, moving into a phase 3.
Doutora Alexa, restam 2 minutos para o encerramento do bloco.
I would like to thank you, and I would like to know if you have an additional comment, because we are about to finish this section. We have like 2 minutes already to go.
I think one thing that we have to address here, this is the Brazilian National Academy of Medicine event. There's a lot of non-ophthalmologists here, maybe. We have to address that there is no clinical therapy approved stem cell based for patients anywhere in the world. All we're talking here is research. It's very promising. We're very excited. But to make the doctors that are watching to be able to orientate their patients that there is no clinically approved therapy stem cell based anywhere in the world. So if any of your patients with retinal diseases ask you if they should go to China or Thailand or anywhere else and pay like $1 million to get injected in the vitreous with bone marrow cells, tell them not to go, because we're still years ahead of a clinically approved therapy. I think that's something that we have to leave as final comments. And I would like to thank everyone for the invite. Thank you, Michael. Thank you, Caio, Alexia. I think it was really great. I learned a lot. And thank you very much again for this great event from the Brazilian National Academy of Medicine.
Thank you, Rodrigo. Your comment is really important. And Dr. Michael, would you like to do an additional comment?
I think that's really a great way to leave it. Yes, these are exciting times, but these are yet to be proven therapies. And again, if anybody asks you to pay even 5 reals for your injection, that's a problem. So these are all experimental therapies in academic medical centers that are important, but early stages. So thanks everybody for listening today, and have a great day.
Thank
Michael,
you. Dr.
I'd like to thank you not only for being here, your excellent comments, but also for all those years of support, continued support, helping us to educate the young generation in Brazil. Thank you so much. Have a nice weekend.
Thank you. Thank you so much. Bye-bye.
Bye.
Thank you. And it's for me, it's a special honor and privilege to have you here, Michael. And it's very, very kind of you to talk with us today from this. It's in the National Academic Medicine here in Brazil. So thank you very much for your talk.
My pleasure. Talk to you all soon, I hope. Enjoy.
Thank you.
Então, obrigado ao Rodrigo Brant, ao Michael, Alexa por essa discussão, e ao Caio também, né, que entende muito de célula-tronco, que ficou junto com o Michael. E vamos dar sequência agora num módulo que é muito importante, né, que a gente discutiu muita coisa do que o médico, como tratamento, pode fazer, mas eu acho que aqui a gente também tem que discutir muito em dar um conforto para o paciente que às vezes a gente não conhece, né? A gente não consegue. Nem sempre a gente tem a capacidade de tratar todas as doenças e resta a gente, pelo menos, dar um bem-estar para o paciente de alguma outra forma. E é o que vai ser discutido agora nessa próxima sessão. Então, eu convido a doutora Kaline Vidal, né, que ela faz parte também do Programa de Jovens Lideranças Médicas, e ela também participa no Núcleo de Oftalmologia da Presidente Sênior e também colaboradora da USP. Então, por favor, Kaline.
Bom dia, obrigada, Eduardo, pela apresentação. Queria agradecer à Academia Nacional de Medicina por me dar essa oportunidade. So let's start in English. Our session will be about low vision blindness, different aspects of low vision blindness. We have 3 amazing speakers from different areas that will raise the level of our discussion. The first one will be Professor Lotfi Merabeh, Director of Laboratory for Visual Neuroplasticity from Harvard Medical School, and he'll talk about assessing functional visual impairments in cerebral visual impairment. Professor Lotfi.
Sim, bom dia. How is the sound okay?
Yeah, the sound is okay.
Excellent, thank you. Obrigado. I'm going to share my screen. I hope this works. And then sharing. Excellent. How is that, Kaline? Is that working well?
It's working.
Perfect. Very good. So once again, bon dia. I want to first of all thank Kaline for the kind invitation to come and speak to you today. Believe me, I wish it was in person. I've had the pleasure of visiting Brazil many, many times, and it's really unfortunate that the situation doesn't allow us to come and visit in person. But I hope you are all doing well and healthy. Kaline asked me to speak to you today about a condition related to visual impairment that is a major focus of our research back here in Boston, and that is the condition of cerebral visual impairment, or CVI. So let me just state, what I think is the most important thing to take away from this presentation, and it's the following statement. The number one individual cause of pediatric blindness or visual impairment is not due to disease of the eye, but rather is because of damage to the brain. So I just hope that sort of resonates with you a little bit. And you can see this nice article that came out from the National Institutes of Health, National Eye Institute, discussing this very, very issue. And you can see here vision loss in children whose eyesight may be 20/20 requires new diagnostic and teaching strategies. So you may ask yourself, how can you use this, the words vision loss and 20/20 vision in the same sentence? But what I hope to convince you again today is that visual impairment has much more to do than just visual acuity. So here is the story that I would like to tell you and how we got involved with this line of research. This is the Perkins School for the Blind. It's located just a little bit outside of Boston. It is the first and oldest school for the blind in the United States. Helen Keller was a student here. When I was an intern in optometry school, I spent a lot of time working here, and I still have a very close relationship with this school. If you looked at the sort of typical Perkins child 30, 40, 50 years ago, you would have found a child that would have been blind due to ocular causes. It could have been infections like syphilis, rubella, and then later on things like retinal diseases. We also saw many children with retinopathy of prematurity. And these children would come to Perkins and do very, very well. They would learn Braille. They would learn, for example, how to use a cane, and they would get their education and then move on and remain independent in their lives. Then about 20 years or so, something changed at Perkins. The profile of children that were enrolled at the school was very, very different. Many of the children had some degree of visual function, some degree of visual acuity, but were presenting with much more complicated backgrounds. So they had other neurological issues, they had perhaps a complex birth history. And what they found is that these children who are now presenting at Perkins were not doing as well in school. So they had difficulty learning Braille. They had a hard time using a cane, for example. And the question is why? Why is the profile of children at Perkins so different? And why are they having such a hard time learning this traditional curriculum that has worked very, very well in the history of the school? An interesting study that was done in the United States, they looked at over 3,000 children across the country who were enrolled at schools for the blind and rank ordered the top diagnoses that children had enrolled at schools for the blind. And the number one diagnosis, you may be surprised to hear, is indeed CVI, cortical or cerebral visual impairment. That is to say that the majority of children who are enrolled at schools for the blind are visually impaired or perhaps even blind due to brain damage as opposed to some sort of disease at the level of the eye. So the question is, how did this happen? Why is this massive shift in population demographics? And the answer is the majority of these children who have CVI are born either premature or have some sort of complexity at birth, and we are saving them. 50, 60 years ago, these children would have died. We did not have the technology or the emergency care or neonatal care to save them, and they are being saved today. They are surviving, they are living longer, and they're living with various complications, including visual impairment. So that's where these children come from. I'll talk a little bit more, again, just some background if you're not familiar with this particular condition. So CVI has been traditionally sort of described as abnormal visual function, despite, quote, a normal eye examination. And that's actually not true, because there are many children that do have some form of ocular issue. It could be strabismus, it could be optic nerve pallor, something at the level of the eye. But I think a better definition that came out more recently in 2018 is verifiable visual dysfunction, which cannot be attributed to disorders of the anterior visual pathways or potentially co-occurring ocular impairments. In other words, the child presents with a series of visual impairments that are due to damage at the level of the brain and cannot be explained by problems at the level of the eye. Visual acuity, as I mentioned, can range from normal to profound blindness, so everything is possible in terms of visual acuity. Many have visual field deficits, and that's usually in the inferior visual field. They may have reduced contrast. They may have ocular motor disorders that is often very present as well. And the key issue is that there tends to be a complex medical history either before or around the period of birth, some sort of perinatal neurological complication. So there could have been a hypoxic or ischemic event, trauma, infection. Many genetic and metabolic causes are becoming more and more evident as well. Typically, there is some neurological comorbidity, sometimes cerebral palsy, could be epilepsy or seizure disorder. And often, but not always, there is some characteristic neuroradiological finding. So if you do imaging and you look at the brain of these children, often we see some sort of evidence of damage. That might be periventricular leukomalacia or PVL, some sort of neonatal encephalopathy, or some sort of injury at the level of white matter, the connectivity of the brain as well. The interesting thing, I think what's really universally sort of characterizes these children with CVI is that there is the presence of these higher order visual processing deficits. So for example, visual spatial, complex motion processing, visual search, attention deficits, and it's been referred to as dorsal stream dysfunction. You may remember that the dorsal visual stream from the occipital cortex to parietal to frontal cortex is responsible for spatial processing, as opposed to the ventral stream, which is the occipital temporal cortex, responsible for object recognition. Sort of the universal characteristic, if you will, of CVI is this dorsal stream dysfunction, this really inability to deal with complex spatial information. So for example, children often will tell us that they cannot walk and see at the same time. Or if they're riding in a car, for example, they don't know where the exits of the road are or anything like that. They can't process information that's moving while they're moving. Younger children, for example, you show them their favorite toy, you then put that toy in a toy box and they can't find it anymore. They have to take the toy box and they have to dump it. We call them dumpers. So they have to spread out all the toys so they can find that favorite toy. Older children, for example, will tell us that in high school, when they walk through a corridor, they can't recognize their friends or their locker or their classroom. So clearly what's going on here is not a problem at the level of the eye. This is a processing problem at the level of the brain. And we need better tools and better ways to try to characterize these deficits, right? So how do we do this? How do we characterize, or what does this patient actually see with CVI when they interact with the real world? The unfortunate thing is that we have very, very good visual function measures like visual acuity, perimetry, contrast, and so on. But these are not adequate when it comes to characterizing these higher order visual deficits, right? Many of the children that we work with, for example, have 20/20 vision or very, very small changes in visual field. But the nature of these visual deficits are much more complicated And just visual acuity, perimetry, things like that just doesn't characterize them. Even if we try more complicated, quote, complicated psychophysical stimuli, again, children don't really like this, right? They say, you know, dots, stars, letters, they're boring. They really don't want to look at these sort of things. So we have good stimulus control when it comes to our classic visual function tests, but very poor ecological validity. In other words, it doesn't look like anything like the real world. The other side of the spectrum is looking at the real world, right? Because if you're a child, that's what you're more interested in. Like I said, trying to find your favorite toy in a toy box. So really what we want to do is assess functional vision. The problem with the real world is that we have very poor stimulus control. We don't know what's going on. What are the changes? Is it the lighting? Is it the number of objects? Is it the color of the objects? So the question is there a middle ground between visual function and functional vision? And what I propose to you today is there is, and we think it's virtual reality. Because virtual reality allows you to have good stimulus control. You are creating the environments, but at the same time, you can create very, very lifelike and functionally relevant or behavioral relevant environments where the child or the patient can engage in a much more robust fashion and a more naturalistic fashion. So that's what I want to talk to you about today in terms of some of the work that we're doing. I also want to mention that when we're assessing children with CVI, we combine desktop virtual reality with eye tracking. There's a lot of great technology out there now. This is a Tobii eye tracker. Very, very simple, very easy to calibrate. It's being done, for example, even in pediatric populations. And we use eye tracking because, as you know, eye tracking or eye movements, I should say, or visual search as a task requires many, many parts of the brain. There are deep ocular motor nuclei in the brainstem. There's the frontal cortex for attention, obviously the visual cortex, parietal cortex for spatial organization, frontal eye fields to move the eyes, again, search, temporal cortex to recognize objects. So in other words, when you're doing visual search, you are recruiting multiple areas of the brain. It's quite demanding on the brain. And if that brain has any type of neurological injury, the chances are good that we'll see some sort of deficit. Right? So here is the first task. There are many virtual reality tasks that we've developed, but I'll show you some data from one in particular that we call the virtual toy box. And what this is a screen like this. There is an eye tracker on the bottom, as I said, and we've created this 5x5 matrix of toys, and what the child has to do is pick their favorite toy. It could be a yellow duck, a blue truck, or an orange basketball. And this is important because the child has to be able to recognize the object in isolation. And we create 3 different scenarios. A low task demand situation where the target is presented with only one type of distractor, medium where there are anywhere between 4 to 6 different type of distractors, and high where there are 7 to 9 different type of distractors in there. And the theory is the higher the distractor number of unique distractors, the more difficult the task is. We also create scenarios or control scenarios where a second toy, for example, can be the same color. Because we want to know, is the child identifying the object because it understands its shape and recognizes its shape, or is it using another cue like color in order to identify it? And then we have sort of an extreme or demanding sort of scenario where we create maximum or background clutter, because we find that many of these children get very, very confused and have a hard time recognizing objects when a visual scene is particularly complex. So we then randomize all these conditions. We then present it to the child. We do the eye tracking, and this is what the performance looks like. I'm going to show you a head-to-head comparison here of a control child with a child with CVI. They're both roughly in their early teens doing the same task. It's a head-to-head comparison. I've slowed it down a little bit as well. And this yellow blob that you see on the screen is where the eyes are. This is where the child is looking, right? And the task is simply to find the blue truck that's on the screen. And the first thing you should see is, do you notice how the CVI child can get to the blue truck? There's no question. But the path is much more complicated in order to get there. Here's the color match. Do you see how the CVI child has to go back and forth and check in order to be sure that they've got the right one? Here is that background clutter situation. In this case, the child found the blue truck. In this particular case, the CVI child missed it completely. This is not something you can pick up with visual acuity or perimetry, or even, for example, with your finger or tracking or anything along those lines. Clearly, something's going on at a higher level, cognitive level, that we need to characterize. You might be saying to yourself, well, how do you know that this child doesn't have just an ocular motor problem to begin with? And it's actually not the simple situation. What I'm showing you here are the same 2 children. On the left, this control, on the right is the CVI child. And this is when the toy is by itself. And you notice how the CVI child is able to get to the blue truck very, very easily? There's no problem. There's no long path. It gets to it right away. So clearly, it's the complexity of the visual scene that's creating these perceptual problems for the CVI child. And it's interesting because many of these kids tell us that after a day at school, they're exhausted. They're very, very tired. And we think it's because their visual system is working so much harder to do exactly the same task as their classmates. We can actually put data to this. We can quantify it. What I'm showing you here is the confidence ellipse area. This is the overall area of visual search that the child has to, or the child actually expresses as they do the task. So the higher you are on this scale, the worse you're doing. And on this scale here is the number of unique distractors. So the more you move to the right, the harder the task is. So what we see in our controls in blue is that as we go from low, medium to high, it's essentially flat. There's a slight uptick between medium and high. So in other words, as the task gets a little bit harder, the performance gets a little bit worse. But here it is in CVI. So first of all, at the low level, they're starting already a little bit worse. And as the task demand gets higher, notice how the steepness of the curve rises tremendously. And we think it's this sensitivity to task demands that makes or characterizes CVI. So as task demands become harder, their visual system starts breaking down more and more. Now, this is important because if this child, for example, was to do a visual acuity test for perimetry, which is quite simple, they could do quite well. But if you ask them to actually operate in the real world, that's where those visual deficits start showing themselves. A second piece that I'll add to this that's very, very important is we have a subset of CVI participants who have excellent visual acuity, 20/20, 20/25 visual acuity. And what we find is that when we test those children, the performance is identical. So good visual acuity does not get you out of this visual impairment. You can still have really marked and dramatic changes in terms of your visual perception, even if you have high visual acuity. Last thing or a couple of things I'll just leave with you. We have been now combining this research with virtual reality with electrophysiology to get a better understanding of how the brain is handling this information. So we've combined our virtual reality task with wireless EEG recording. In fact, that's me sitting in front of the screen here. I'm wearing a 20 electrode montage. And what you notice about this is that the system is wireless. So the child, for example, if they have to take a bathroom break or take a break or so on, it's okay. They're not connected to a machine. The information is gathered wirelessly, so it's much, much easier to record in children. The second thing that you'll notice is this yellow box is an accelerometer. So as the child moves their head, we're recording the motion of their head, and we use those signals to filter out in the analysis to get a much smoother or a much cleaner, if you will, a signal to noise ratio. That combination of virtual reality, the toy box task with EEG gives results that look like this. Here's a control participant on the top. You're looking at the back of the brain. Here's the occipital cortex. This is the onset of the toy box. And then this is the initial 400 milliseconds before they actually move their eyes and get to the target, right? So this is that initial 400 milliseconds right after the presentation of the toy box. And in the control subject, you see this really, really nice, robust activation in the occipital pole, including parietal areas as well as temporal areas. Here it is in a CVI individual for comparison. The first thing you should notice is that there is indeed activation in the occipital pole, but do you notice how the parietal cortex from occipital parietal to frontal shows a much, much lower amplitude? And this seems to fit, again, with this theory of dorsal dysfunction. So on an electrophysiological standpoint, the activity of the brain in CVI seems to also explain these spatial or these visual spatial processing deficits. There is another piece of data that's quite interesting with this that you may be familiar with. There is a technique called time frequency decomposition, which allows you to look at the overall frequencies of the brain at particular parts. So we look specifically in the occipital cortex, and we use this plot here where various frequencies are plotted as a function of time. So 0 is the onset again. Moving towards the right is as the toy box is presented, and they have to do this search. When you do this, there is a very, very unique frequency called alpha desynchronization that is always present in the case of neurotypical development over the occipital cortex, which is very much a marker for the integrity of visual processing. So it's a product of information coming into the visual cortex, as well as the rest of the brain feeding back to the occipital cortex as well. So it's a combination of processing mechanisms. And this desynchronization that you see here in blue gives us very, very much an index of how well the visual cortex is functioning. Here it is in controls. This is what it looks like in CVI. You can see right away that this alpha desynchronization is completely absent. And on top of that, all these other frequencies bands, including theta and gamma, are now completely desynchronized as well. So we think that what's happening here is that there is a complete lack of coordination or poor coordination of neuronal signals in the case of CVI that we think is somehow related to their issues. And very often these children tell us that they have a hard time, again, processing visual scenes. It takes them some time. And we think it's because it's a visual system that is not optimized to handle visual information correctly. The last piece I'm going to share with you is we are now looking at diffusion-based imaging to look at the white matter connectivity of the brain, to put the third piece to this. And we use a technique called HARDI, which is high angular resolution diffusion imaging. Very briefly, all diffusion-based imaging is based on looking at the movement of water molecules. So as water moves through the brain, it gives us an indication of how brain cells or neurons are aligned. So if a water molecule is moving completely randomly, you're essentially looking at a part of the brain that does not have myelination. So the central cerebrospinal fluid, for example, or inside the ventricles. In contrast, if a water molecule is moving consistently in the same direction, it's probably oriented with an axon. We call this anisotropic diffusion. The best analogy I can give you, it's kind of like trying to follow the flow of traffic in order to figure out how roads are laid out in a city. That's sort of the rationale. So we did this in the case of CVI. This is a control on the left. This is an individual with CVI on the right. This is a three-dimensional rendering, and I'll show you what the results are when you do this analysis. So here we go. You see the gray matter of these two individuals spinning, and these are the white matter connections inside the brain. We then ask the software to virtually dissect the connections from the occipital pole to the right, or the rest of the brain, I should say. And in the control, you see this beautiful, beautiful arborization. This pathway here from occipital cortex to parietal to frontal cortex, the superior longitudinal fasciculus, corresponds to the dorsal processing stream. This pathway here from occipital cortex down temporal cortex is the inferior longitudinal fasciculus. This corresponds to the ventral processing stream. And right away, it's quite evident, you can see in the CVI individual, why the ventral processing stream seems to be largely intact. There is serious, there is much, much more reduced connectivity, overall integrity and arborization along the dorsal stream. So we think that the white matter connectivity, the activity that we see with EEG, the clinical profile, plus the behavioral data that we see on visual search seem to fit together and give us a complete picture of what's happening in terms of higher order processing problems in CVI. With that, I want to say thank you. I hope I was all right in terms of time. As I mentioned, I've had the pleasure to visit Brazil many, many times. This is me in Natal. I hope I get the chance to come and visit in person again. And Kalini, I thank you again for the opportunity to speak to you today.
Thank you, Professor Lofty. I would like to ask you, because we have in Brazil, the last casuística I saw, 33,000 patients with blindness and 100,000 with low vision. And I don't know exactly the number of CVI in Brazil, but as you told us, it's a condition associated with many neurological disorders, especially Zika virus.
Yes, yes.
And I would like to know I would like to know what the status regarding CVI and childhood visual impairment in Brazil. Could you tell?
Yeah, unfortunately, I don't know as much. I can talk about some of the colleagues that I've worked with and what they've explained. You're absolutely right. My understanding is CVI is very, very prevalent in Brazil, although the actual numbers, as you mentioned, are not well understood. And what struck me, or what I was quite surprised, exactly what you said, is that many of the children with CVI in Brazil it is indeed associated with Zika virus, which means an infectious cause, which is very, very different than the sort of presentation that we're seeing in the United States, where it tends to be more with some sort of perinatal stroke or hypoxic or ischemic event. I think that's interesting because it may mean that there are subtleties of CVI in a country like Brazil that may be different than, say, in the United States. It also means that potential treatments or ways to circumnavigate the problem are going to be different in Brazil compared to the United States. Certainly, in the case of Zika, there are going to be public health issues. There are going to be various concerns. Hopefully, it's something that is not always going to increase as better public health measures are put in place. The other thing that's interesting is that it actually may be seasonal, right? Because it could be a function of how the virus is presenting, waxing and waning, and so on. So I think the situation in Brazil is very, very complex because you have these other potential causes that we don't see, for example, in the United States. Things like encephalitis, complications, infectious causes, which makes it much more challenging. Because one thing, I'll just end on this comment, what makes CVI very, very challenging is the fact that there are so many different causes. And because there are different causes, there are different presentations. So how to manage it, how to potentially prevent it, what are the public health policies to implement become very, very challenging because there are so many different causes.
Okay, I think we have one question. No, three questions. Camila Ventura, please, you can make a question.
Yes, first of all, I want to congratulate you, Professor Merabet, for everything that you're doing. And it was so enlightening to hear from you all of what
Obrigado.
you. So let me introduce myself. I'm Camila Ventura, and I'm a retina specialist here in Brazil, and I do peds retina. And I have been working with congenital Zika syndrome since 2015. We were studying these eyes of children with congenital Zika syndrome in our institution here, Alumni Foundation. And we were the first to bring up that issue of CVI because we found out that 1/3 of the children presented ocular manifestations, but all of them presented severe visual impairment. So we performed VP, visual evoked potentials in these children, and we found out that all of them had actually the potentials were slowly reaching the occipital part of the brain. So there was a delay, right? And because of that, we came up with the CVI. But my question is, these children, they have motor, so the physical impairment, right? And they many times they cannot fixate. So how do you, I wonder, how can we study these children using your technology? And we cannot have them reach out and point out to the toy that they want to pick, and many times they cannot fixate. So how does it work for those children?
Yeah, so Camila, that is an excellent question, and I also congratulate you for taking on such a challenging condition and being at the front line, among the first to take on something that's obviously extremely important and challenging. You raise a number of good points. You're exactly correct. Because of these complex presentations, when there is this motor component, you need some sort of output. You need some way to assess whether or not the child saw it or didn't see this. You brought up the issue, for example, of visual evoked potentials, which is great because it's a completely passive assessment using flashes or gratings or checkerboards, and you get a sense of whether or not the visual cortex is somehow active. I have to tell you, I'm not a big fan of visual evoked potentials in the case of CVI, simply because I don't think it's particularly diagnostic. There are many kids, for example, with 20/20 vision and show impaired visual evoked potentials, and vice versa. The other thing I would say about visually evoked potentials, it's kind of like you have, I think, DHL or FedEx in Brazil. Yeah. So a visually evoked potential is kind of like sending a letter with like FedEx. It got there, but you don't know if the person actually read the letter and understood the content. And that's exactly the problem with visual evoked potentials. It gets to the brain, but it doesn't say anything about whether or not the child actually understood or it could interact with the visual stimulus. And because we are dealing, as you said, with higher order problems, we need a level to get there. So then that comes back to the point is, what is that motor output? We use ocular motor because if the child is nonverbal or has, for example, a coordination issue, typically we can get around that because of the eyes, right? They are just simply answering overtly with the eyes. If you now add this layer of complexity that the eyes themselves are difficult, then it becomes much more challenging. What I would suggest, and I have some colleagues who have worked specifically with the Zika case in Brazil, is many of them, what they try to do is use stimuli and tasks, an iPad or something to that effect, where the child is engaged. That is the most single important thing I think you can do, is whether or not even, there is strabismus or ocular motor apraxia or issues. If the child seems to at least be engaged, that is your overt response. And then it's simply a question of comparing whether or not that particular visual stimulus, present or not present, elicits that reaction. So you are really sort of marching down, if you will, to the most basic overt reaction you could possibly get. And the hope is that as the child grows, as the situation gets a little bit better, because typically CVI does improve over time, could you then track that child and show progress over time as well, using the same sort of simple responses? And hopefully then you can then develop more complicated type assessments as the child's function improves. Does that make sense?
That does make sense. And just one piece of information that I think is really interesting that I have been learning is using a device that we're working with Purdue University right now. Mothers wanted to understand, does my child understand that I'm the mother? Do they see me, like they feel me? What is it? And we found out that their hearing impairment is not that present. So we decided to check if children with congenital Zika syndrome, they knew who the mother was. And so we are using heart monitors. I don't know if...
Oh, this is very interesting. Okay.
And we're using heart monitors, and they have an algorithm where they have a control group of the same age children. And what they understand is when a mother calls on their child's name, the heartbeat changes, the frequency. Yeah. And when so it's a common, first, it's their name, right? They're being called on their name. So they recognize their name and also the mother's voice. And then we have, it's an experience. So we have therapists calling on their name and then the therapist calling another child's name. And it's fascinating because it is working. Like children with congenital Zika syndrome, their heartbeat answers to the mother's voice and to their name.
Yes.
So I'm wondering if we could use that technology where we are having some kind of response to use your technology over it.
Sure.
I'm sorry, but we have to move on. I think Dr. Juliana has one more question.
Sorry, but excellent point. Sorry, please.
We can talk about later, Camila. It's very interesting to do a collaboration with you. But let me see, Dr. Juliana, question, please.
I would like to add that here in São Paulo, I have a close work during these years with Dorina Noil Foundation and also with the Deaf and Blind Association. And I have been seeing through all these years that the multiple affections, disabilities are really increasing. Yes. And the only deficiency are more being dealing with the local schools, with inclusion and the local. And in the major institutions, we are having more of the multiple affected disability patients. Yes. So I think it's quite the same as US.
Absolutely. Thank you for that point. And again, explaining that the situation is much more complicated than it was for schools of the blind in the past. You're absolutely correct. I will just add one thing that is a big challenge that we've worked on here in the state of Massachusetts. As you mentioned, because these children have other issues, it could be sensory in terms of hearing, it could be tactile, language, and so on, it creates a much more complex scenario. And it's interesting because many of these children may have a level of visual acuity or visual field that does not allow them to qualify for benefits. They are not considered blind per se. But when you add all these neurological issues on top, the child becomes extremely visually impaired. So one thing that we have worked on here in Massachusetts is that we have changed the regulation. So that is to say that we can register a child with CVI as blind or visually or functions as a child who is blind, even though their visual acuity and visual field may not necessarily pass that threshold. Because we look at it holistically, we look at the potential effects on learning, development, and independence. And I don't know what the situation is in Brazil, but I think that that's an important point, is to rethink what is the definition of visual impairment beyond just simply visual acuity and field.
Yeah, we usually use the word central blindness.
Okay.
And usually I go to this one of these clinics as a volunteer once a month to try to teach people how to deal with these children. So I do an examination and I try to tell them, so play more on this side or do something else so that they can stimulate the child.
Excellent, excellent. Well done.
I think Professor Rubens wants to do some questions.
Well, that's a great talk. Thank you so much. Do you have any specific information on toxoplasmosis and any different behavior from, for instance, Zika, toxoplasmosis? And second question, do you believe this technology could maybe be used also CVI in adults in chronic disease such as long-term COVID?
Yeah. Oh, wow. Lots of good questions there, Professor. In the case of toxo, in terms of my understanding, we haven't worked specifically with children with toxo, but for me, I've always kind of see that as largely an ocular-based issue. That's not to say that there isn't downstream neurological effects, but I think for me, the case of toxo fits more with the presentation of ocular-based visual impairments and disease. And I think, again, a lot of the strategies that we have in that particular case work and work well. But again, that's not to say that there cannot be potential cognitive issues or downstream issues that need to be addressed. But I do think that toxo is one that is more sort of on the front end. In the contrast, or to contrast, retinopathy of prematurity is a good example of a hybrid situation where there's clearly an ocular optic nerve head issue that's then leading also to downstream effects, and ultimately, because of the prematurity, typically there are changes at the cerebral level as well. So ROP is a very challenging condition because of those two components. And then you kind of march on where you move away more and more from the eye and more into the cerebrum, and that's what kind of changes the strategies that you're going to employ from a diagnosis as well as potential management. Your question about extrapolating this technology to other technologies. Yes, or other conditions. Yes, I do think there is that potential, but I just want to make clear that one of the biggest challenges working with pediatric populations is they just don't like to test. And they specifically don't like to test when they don't understand the point of the test. So the virtual reality was really designed to keep them engaged, to keep them in a behavioral relevant task. And historically, I think adults still do well with following lights and and classic sort of psychophysics types testing. So we really wanted to design environments specifically for the pediatric and younger population, because we feel that if they are engaged and they are doing things that are behaviorally relevant, then they're really operating at optimal. So I would say that while I think this technology can apply to adults and even late onset type neurological conditions, it's really, really designed for the younger populations because there's just so little out there for them.
Okay. Thanks so much, Professor Lotfi. It was amazing talk.
Thank you.
And
thank you so much.
We have to move on for the second part of our session. Thanks so much.
Thank you.
Então, agora nós vamos para a nossa segunda parte do evento, que será em português. Eu queria chamar o Dr. Henrique, que ele é psiquiatra, trabalha com cuidados paliativos no Hospital das Clínicas e no Hospital Sírio-Libanês, e a doutora Sung, que é especialista em retina e eletrofisiologia visual e trabalha com reabilitação visual na sua clínica privada. Bom dia a todos. Eu queria começar com o Dr. Henrique, Doutor Henrique, a gente fez uma analogia da perda visual, a sensação da perda visual ao luto. Quando a gente pode reconhecer que o paciente está passando por um fenômeno patológico ou não patológico em relação à perda visual?
Bom dia, Kalene, bom dia, Sung. Professor Latif, excelente apresentação, muito boa, profunda e ampla, e com ciência de ponta. O luto, ele acho que é possível fazer essa extrapolação, né? Há uma perda em curso e uma perda progressiva, né? Existem perdas agudas e perdas, né, crônicas aí, progressivas, que a gente vai observar. Então, essa extrapolação ela é possível, né? E um processo de um luto antecipatório, como se fosse a morte final da visão, né, da capacidade visual, que vai sendo progressivamente perdida, ao passo que você vai tendo que fazer ajustes ou adaptações, né? Essa plasticidade de adaptação que o luto exige, né? Trabalhando muito esse conceito do concreto, da morte concreta com a morte simbólica. Então, acho que as reações de um luto, elas são reações absolutamente normais. 80% das pessoas têm um processo de luto normal diante de uma morte concreta, da morte de alguma pessoa amada. Então, existe o risco de complicações, isso tem que estar sempre atento aí a comorbidades psiquiátricas que podem estar presentes, né, diagnóstico diferencial, né, de uma depressão, de um transtorno de ansiedade, mas, de maneira geral, esse processo ele ocorre de uma maneira natural, né, onde vão ter aí algumas emoções esperadas, como negação, e às vezes aquele paciente que demora para buscar ajuda porque ele vai entrando num processo de negar aquela realidade, adaptações, ajustes, negociações aí com relação ao processo, tristeza, né, que às vezes pode se considerar até ou erroneamente entender como depressão, essa raiva, né, até que se chega a um processo de aceitação. Mas existe um conceito de luto antecipatório, então eu entendo que haveria um luto antecipatório por essa perda em curso que está por vir, essa morte que vai acontecer, e eventualmente aí um processo de adaptação sincrônico com isso, né?
Eu queria perguntar para a doutora Sung, quais são os desafios que você enfrenta, doutora Sung, na sua prática de reabilitação visual e como que você maneja?
Bom dia a todos, obrigada pela oportunidade e pelo convite. Por causa do adiantar da hora, eu vou ser bem breve. Acho que assim, no dia a dia, acho que os desafios maiores são para o paciente que essa questão da reabilitação é um processo constante de aprendizagem, então há um trabalho que tem que ser junto com o paciente, com o médico que dá assistência e os familiares. Então, muitas vezes, como dependendo do grau de deficiência visual, histórico de vida do paciente, nós temos altos e baixos. Então, o desafio maior é convencer um paciente que é um processo que leva tempo, que é para o resto da vida, e que nós vamos encontrar altos e baixos, barreiras maiores, desafios maiores ao longo da vida. E também passar isso para os familiares, para eles também aceitarem que esse membro, esse familiar com deficiência visual precisa do apoio. Então, muitas vezes a paciente não consegue ter uma evolução satisfatória por causa da falta do apoio familiar, né, do incentivo. E outra questão do desafio que eu encontro é também junto a oftalmologistas. Eu acho que o oftalmologista também tem que entender que a reabilitação não começa quando a visão é PL, percepção de luz, SPL, ausência de percepção de luz ou conta-dedos. Como é um processo de aprendizagem, quanto mais cedo o paciente ingressar nos trabalhos de reabilitação, essa questão do luto também será menor. Então, conforme, dependendo da doença, vai progredindo e a visão vai piorando, muitas vezes a pessoa já conhece o trabalho de reabilitação e tem uma aceitação, digamos, um pouco mais rápida, um pouco melhorada, e até tentar diminuir as outras doenças psíquicas, né?
Eu acho até que você tinha perguntado no chat para o doutor Henrique, você tinha algumas dúvidas em relação a lidar com o paciente. Você quer fazer as perguntas para ele, aproveitar a expertise dele sobre o assunto?
Porque eu vejo assim, que muitas vezes os pacientes demoram muito para fazer a aceitação, demoram muito a aceitação e trabalho de reabilitação. Então, a gente vê muitos casos de desistência. Então, a aderência desses pacientes com deficiência visual grave ao trabalho de reabilitação é muito baixa, né? Então, o que nós podemos fazer como oftalmo para melhorar essa aderência, melhorar essa aceitação, eu sei que é um trabalho muito difícil e sei que tem que ser um trabalho personalizado, individualizado, mas de alguma maneira porque a gente sabe o quanto de benefício o paciente terá com a reabilitação. Então, como é que a gente pode mostrar isso, né? Essa é uma dúvida constante no dia a dia.
Henrique?
Muito boas colocações, né? Eu acho que essa correlação com o luto ela é válida no sentido de que, fazendo um paralelo com quadros oncológicos de doenças terminais, né, onde você sabe que o desfecho ocorrerá em progressão em algum momento. E existe uma vivência, um paradoxo existencial que é: eu estou esperando pelo melhor e, ao mesmo tempo, me preparando para o pior. Então, isso vai trazer alguns momentos em que há uma abertura de esperança para que eu possa me curar, que surja algo que a gente vê de inovação, de tecnologia, o investimento que é feito é algo impressionante, né? Assim, observar esses avanços, esse nível de discussão que a gente vê hoje em neuroplasticidade, e ao mesmo tempo ter que assimilar que este processo vai ocorrer, né? Então, o luto, né? Então, acho que pensando no profissional, no oftalmologista, conhecer o processo de luto, porque a aceitação ela é exatamente o que a gente entende pelo processo de luto, é um processo, né? Aceitar a realidade, e uma realidade que vai progressivamente mudando emocionalmente, né? Uma teoria, né? Um modelo que se tem de entendimento do luto hoje é um modelo dual, em que o paciente, em momentos, ele vai estar muito ligado à desesperança, aquilo vai chegar, é inevitável, e aí vai para um polo mais de tristeza, de não querer eventualmente fazer os cuidados, a reabilitação. Isso tem um movimento pendular que vai para um outro extremo, em alguns momentos, de abertura. O profissional entender que isso pode acontecer dessa maneira, tentando motivar o paciente à reabilitação, aos cuidados e à tentativa de adaptação, né, por outras vias sensoriais, de rede, né, de suporte, que são infinitas. E no cuidado paliativo isso é bom, porque é um time multiprofissional. Terapia ocupacional, dog terapia, né? Você tem os cachorros, os animais que podem ajudar muito, inclusive cão-guia, pensando em perda visual, atividades, inclusão, adaptação, como foi falado de escolas, né? Tentar aí trazer essa criança para uma sensação de pertencimento a esse mundo. Isso vai ajudando a entender, a partir do momento em que essa pessoa estiver, né, do processo, da curva da doença oftalmológica ou da doença clínica, nós vamos entendendo esse processo e aí, ao mesmo tempo, lidando com a nossa própria impotência, né? Porque eu acho que me lembrou, inclusive, um documento da Academia Nacional de Ciências nos Estados Unidos, quando eles falam dos centros compreensivos oncológicos, de 2008, em que eles falam sobre o uso do investimento massivo de recursos nas novas tecnologias do câncer e que isso poderia ser utilizado, né, pensando no mundo de acesso universal, em equipes multiprofissionais, em cuidados paliativos, em abordagens aí proporcionais dentro desse avanço, né? Que um vem junto com o outro, é exatamente esse o ponto. Pode surgir um tratamento que traga resultado, que eventualmente não vai ser acessível para todo mundo, né, por conta do custo, mas simultaneamente você pode trazer conforto, qualidade de vida para essa pessoa, para essa família e também para as equipes, né? Porque eu acho que a questão da impotência é algo que nós profissionais de saúde temos que lidar nas mortes concretas e simbólicas. Na perda visual, eu entendo que há uma morte sem cadáver, né? É uma morte simbólica e, ao mesmo tempo, uma possibilidade de enxergar o mundo com outros recursos, né? Assim, eu acho que é um trabalho do simbólico ajudando a enfrentar esse processo.
Obrigada, doutor Henrique, foi sensacional o seu comentário. Inclusive, eu tive uma ideia aqui que a gente poderia fazer. Existe uma série de podcasts da Academia Nacional de Medicina, seria interessante a gente criar um podcast sobre isso, né, para a Academia Nacional de Medicina, porque é um tópico muito importante. Eu acho que nós, profissionais da saúde, oftalmologistas, que trabalham com visão, a gente não está preparado para lidar com a perda visual, né? A gente só se preocupa em proporcionar a melhor visão para o paciente. E a gente também fica perdido quando isso acontece. E todo profissional da área da oftalmologia, independente da subespecialidade, vai ter isso em algum momento, mesmo na cirurgia de catarata, refrativa, isso pode acontecer, faz parte, assim como a morte está para a vida, a perda visual está para a visão. Então, eu acho super importante a gente estar discutindo esse aspecto. Inclusive, a gente vai contar com uma participação especial aqui no nosso evento, né? Eu vou chamar dar o seu depoimento a doutora Alessandra. A doutora Alessandra, ela é Research Fellow no INIH, e atualmente ela está sendo aqui convidada, na verdade, como paciente. Ela teve uveíte autoimune na infância, perdeu a visão de um dos olhos aos 6 anos de idade e acabou evoluindo com visão subnormal do outro olho. Então ela convive com a baixa visão praticamente a vida inteira. Alessandra, muito obrigada por ter aceitado o convite. Eu queria, na verdade, que você falasse um pouquinho como você lidou com a perda visual e como foi o papel do oftalmologista nesse processo.
Aline, eu queria falar algumas palavras antes da Alessandra.
Claro.
Eu conheço a Alessandra desde que ela tinha 6 anos de idade. A Alessandra, apesar da visão muito fraca no olho único que tem, é uma investigadora de ponta. Ela continua publicando, ela continua orientando PhD students e pós-doc. E quem vê a Alessandra dar uma aula, não percebe que a Alessandra dá uma aula e manda trocar o PowerPoint, e todos acreditam que ela enxerga perfeitamente bem, porque ela decora todos os PowerPoints na ordem correta. A Alessandra é uma querida amiga, uma das pessoas mais importantes, eu acredito, no nosso programa de pós-graduação, pelo que ela continua produzindo em toxoplasmose. Ela continua a autoria de papers em das primeiras revistas científicas do mundo na área. Então é uma honra ter a minha querida amiga Alessandra falando aqui hoje, Ale.
Oi, bom dia, todo mundo está me ouvindo? Sim.
Sim, tá perfeito.
Okay. Que meu marido estava aqui de guarda. Bom, primeiramente eu gostaria de agradecer o convite de estar aqui hoje como paciente. E como a doutora Kalene já disse, né, ela me convidou para falar sobre a minha experiência com o meu oftalmologista. E assim, ela disse a experiência boa e a experiência ruim. Se eu tivesse alguma experiência ruim, eu não estaria com ele há 42 anos. Então, eu decidi levantar 2 pontos principais que foram importantes na minha formação, e eu vou dar 2 exemplos para cada ponto. Então, assim, o primeiro exemplo, bom, ele teve o prazer ou não, né, de conhecer a Alessandra fase criança, fase adolescente e fase adulta. E na minha fase adolescente, então assim, o primeiro ponto é respeitar o tempo de aceitação do paciente. Esse é o primeiro ponto que eu quero levantar e eu vou dar 2 exemplos. Então assim, no meu período de adolescência, durante esses 42 anos, né, antes, eu tomei muita injeção intraocular e periocular. E assim, era desconfortável, me incomodava e mudava a minha rotina. Uma coisa é o paciente tratar com corticoide e no dia seguinte ele está na escola de novo, e outra coisa é ele tomar uma injeção e ter que ficar sem ir à escola e mudar a rotina para uma adolescente, né? Então, assim, no período da adolescência eu comecei com uma frase assim, lembro bem. Então eu chegava na clínica dele e ele dizia para mim, Ale, infelizmente eu vou ter que te dar uma injeção. E eu dizia, posso ir para casa pensar e eu volto amanhã? É claro que inicialmente até ele falava, você não quer acabar com isso hoje, a gente já liquida, amanhã você está livre. Eu dizia, não, quero ir para casa pensar. E eu ir para casa pensar era entrar no carro da minha mãe, chorar até em casa, chegar, jantar chorando, dormir chorando. E no dia seguinte eu estava bem, feliz, posso dizer, tranquila, e voltava à clínica dele para tomar minha injeção. Então o ponto aqui era um homem ocupado, com uma agenda cheia de paciente, e nesse momento, em todos esses momentos, que não foi só uma vez, foram vários, ele podia ter dito, olha, minha filha, eu estou com a agenda cheia amanhã, não tenho espaço para te atender, então vamos acabar com isso aqui agora. E ao contrário disso, ele sempre respeitou, dizia, ok, vai para casa, amanhã a gente se vê. E assim, agora, o segundo exemplo, indo muitos anos para frente, porque se eu falar de 42 anos, vou ficar até amanhã, foi já no processo, assim, de rápida perda visual, já no final. E eu lembro, o Research Fellow eu fiz, hoje eu não faço mais, eu já não sou mais Research Fellow do NIH, mas nesse período foi a perda visual mais pesada, né? E eu lembro que eu ia muito ao Brasil, e uma das vezes que eu fui, já com ajuda para caminhar, do meu irmão até, ele disse no final da consulta assim: Ale, você poderia usar bengala, acho que seria muito legal, tem um curso de orientação e mobilidade, várias instituições têm, e te ajudaria muito, assim, para fazer você mais independente, ou mais segura para caminhar. E é claro que eu não falei, mas eu pensei, esse homem tá louco, né? Tipo, para que eu preciso de bengala? E aí eu respondi, falei, não, imagina, eu vou sarar. Quer dizer, durante 40 e poucos anos eu tomei remédio e sarei, por que agora não ia ser assim? É óbvio que eu estava 100% na minha fase de negação, porque eu fiz uma tese em veite autoimune, eu fiz um pós-doc em veite autoimune, eu fiz um pós-doc em toxo ocular. Então, assim, era óbvio que eu tinha inteligência super suficiente para saber que era irreversível, mas realmente eu não queria ver. E ao contrário dele falar, não, louca tá você, né? Porque você precisa de bengala em algum momento. Ele disse, ok, você pensa, você decide o que é melhor para você, mas eu estou aqui para te ajudar, para te orientar e para te... Assim, qualquer momento você pode vir e me perguntar o que você quiser para te esclarecer dúvidas. Eu agradeci. Então, assim, é isso, assim, sempre nesses 42 anos, eu quero dizer que ele sempre respeitou o meu tempo de aceitação. Nunca me deu um choque de realidade, né? Do nada. Esse choque, na verdade, ele deixou que eu mesma percebesse as coisas. E o segundo ponto que eu também acho que foi super importante foi o você pode ou você não pode. Então, assim, o você pode, você não pode, eu também vou dar 2 exemplos. Sempre quando ia no consultório, ele sempre soube muito, assim, do meu estado emocional, vamos dizer assim. Então, um dia entrei, ele disse, tá tudo bem? Eu falei, eu estava com mais ou menos 19 anos nessa época, e ele falou, tá tudo bem? Eu falei, não, todas as minhas amigas tiraram carteira de motorista e eu não posso. E ele falou assim, você não pode por quê? Eu disse, porque eu tenho um olho só e esse olho vive doente. Então ele me respondeu, bom, todo mundo que tem um olho só pode dirigir. E esse olho doente, quando ele não está doente, você tem uma visão boa, passível de dirigir. Então eu saí do consultório super feliz, fui lá, tirei a minha carteira de motorista, com ela já na minha mão, olhei para ela e disse, não vou dirigir, porque de manhã eu estou bem, de tarde eu não estou, e eu posso causar um acidente e machucar alguém. O ponto é que nunca ele me disse, você não pode fazer algo, e eu decidi sozinha, eu percebi sozinha que eu não podia dirigir. Ele nunca disse, falou, louca, não dá, né? Acorda, você não vai poder dirigir algum dia. E o outro exemplo, que esse, assim, foi uma experiência que eu tive com outro médico, não foi uma traição. Ele, em 1989, 1990, ele foi fazer um sabático no NIH de 1 ano. Eu tinha por volta de 17, 18 anos, porque eu estava no período do vestibular. E ele me deixou com outro médico muito, muito competente. Admiro muito como profissional. Um fofo. Só que o fofo pegou uma bucha, né? Eu fiz o VIT o ano inteiro. Eu estava, assim, com uma crise por mês. E um dia, eu lembro que eu entrei no consultório desse outro profissional e ele me disse, conversei com o seu oftalmologista e ele me disse assim, pergunta para ela se ela tá bem, se ela tá com algum problema. E aí eu lembro que eu falei, eu tô só estressada, estudando muito no período do vestibular. E aí esse outro oftalmologista disse assim, o que você quer fazer? Eu falei, primeira opção, eu quero a área da saúde. Primeira opção é medicina, segunda é fonoaudiologia e terceira, enfermagem. Aí ele fez uma cara de enterro e disse, Ale, pensa bem no que você quer fazer, porque um dia você vai perder a sua visão. E acho que essas áreas seriam muito difíceis para você no futuro. É óbvio que eu saí arrasada, chorei, fiquei com raiva dele. Mas, assim, em resumo, o meu oftalmologista voltou logo depois. Eu fiz a segunda opção, porque a primeira eu não entrei, fiz fonoaudiologia, fiz mestrado, doutorado, pós-doc 1, pós-doc 2, pós-doc 3. E hoje sou uma pessoa muito realizada, feliz. Então, esse você pode, você não pode, eu acho que o médico tem que tomar muito cuidado também com isso. Esses dias eu vi na Foundation Fighting Blinds um blind, né, um americano blind que escalou o Everest. Óbvio que eu não quero escalar o Everest, mas, né, quando a gente quer, pode, talvez de uma maneira mais devagar, mais lenta, mas a gente é capaz de fazer qualquer coisa menos dirigir. E uma outra coisa que eu quero, um complemento, né, para fechar essa parte, quando frequentei Dorina e a ADEVA, que são instituições para deficientes visuais localizadas em São Paulo, 95% das queixas dos deficientes visuais são a falta de orientação após o diagnóstico. Por exemplo, olha, você tem retinose pigmentar e daqui a uns anos você não enxerga mais. É claro, tem mais 10 pacientes na sala de espera, mas não custa o médico perder 5 minutos falando assim, olha só, você vai perder sua visão, mas o mundo não acaba. Você tem um especialista em visão subnormal, tá aqui a indicação é essa. Você tem um psicólogo, um psiquiatra especializado que pode te atender e te ajudar. E você tem aqui uma lista de tecnologias gratuitas ou não gratuitas que podem te ajudar a caminhar, a ler, a usar o seu computador novamente. Então, assim, não deixar que o paciente saia desorientado, chocado, achando que o mundo acabou. Porque, assim, eu fiquei até chocada com o número de pessoas que eu vi que tentaram cometer o suicídio. E fora as que se suicidaram, porque eu não sei, mas eu não achei pouco. Eram muitos deficientes. Principalmente homens, né, que são os líderes de uma casa e, de repente, eles se acham incapazes de fazer coisas, perdem o emprego e tudo isso. Então, acho que esses 5 minutos de orientação que o oftalmologista pode dar ao seu paciente, eu acho fundamental, que foi a maior queixa que eu ouvi dos deficientes. Não é a minha queixa, porque eu tive muita sorte e eu sou muito grata. E acho que é isso. Alguma
Alessandra, pergunta? Muito obrigada pela tua participação. Eu acho que a palavra aqui é acolhimento, é o que falta, e eu acho que isso é uma deficiência nossa da área de saúde. A gente, como eu falei anteriormente, a gente não é preparado para lidar com a perda visual do paciente. Então, eu acho que falta, tanto na educação médica, na faculdade, nas residências, a gente ser preparado para lidar com os aspectos psicológicos da perda visual. E é por isso que esse evento hoje é extremamente importante, da gente falar sobre isso, trazer o teu depoimento, trazer a expertise do Dr. Henrique como psiquiatra, a expertise da doutora Sung, que trabalha com reabilitação visual, né, e falar sobre todos os desafios. Que pena que o tempo foi muito curto para a gente poder falar mais. Eu acho que vale um podcast, com certeza. And I'd like to thank you so much, Dr. Lotfi, for your presentation, for your collaboration. I remember when you were introduced each other, you said that your work is about to care about blind people. I remember that.
Yes.
These words I kept in my mind, and when I have this opportunity to invite speakers for this section, you are the first person that I remember, because your words touched me. Thanks so much.
Thank you so much, Kalini. Thank you.
So much. Eu queria saber se alguém tem mais alguma pergunta antes da gente encerrar.
Eu queria, I'm going to speak in Portuguese if you don't mind.
No, of course, please, Professor.
For you, I tell you, we really appreciate your presence here, and I'm going to speak in English. I believe. I think I speak also not only for me, but also for academician Oswaldo Moura Brazil. This shows the excellence of this program of the National Academy of Medicine. Congratulations to each of you that have really built a fantastic program. Kalini, very nice presentation. Of course, you are invited to have this podcast to the National Academy of Medicine. Not only you, but all of you. We need more. We need to reduce the gap between the rich and the poor, the seeing and non-seeing people, but also very important, the gap between generations. And for me, age 75, have a chance to interact with people bright like you is the best I can expect from my life. Congratulations to each of you. And Oswaldo, I'd like you please to, now maybe you can speak in Portuguese, to have a chance for Portuguese language also, but I'd like you to close the session, please, Oswaldo.
Obrigado, presidente. Eu acho que foi uma manhã muito importante em que a gente viu o futuro da medicina sendo discutido e um futuro que já existe, um futuro que hoje já faz parte do nosso dia a dia, associado a todo esse lado humano, esse lado que é extremamente importante na medicina e que a gente tem que valorizar cada vez mais, porque não adianta a gente ser especificamente só um técnico se a gente não tiver todo esse lado humano que a Alessandra mostrou bastante bem. Eu acho que dar os parabéns a todos que participaram, os coordenadores, os palestrantes internacionais, e como o presidente me autorizou, fica encerrada essa sessão. Muito obrigado a todos.
Eu queria agradecer a oportunidade e agradecer em especial o professor Rubens pela inovação. Acho que o professor Rubens traz para a gente sempre a questão da inovação e ele é o maior exemplo de inovação que a gente pode seguir. E agradecer a oportunidade de, junto com o Eduardo Novais, a gente poder coordenar essa sessão dessa importante academia de medicina.
Obrigado a todos, pessoal. Muito obrigado, muito bom.
Bom domingo para todos. Bye-bye. Have a nice weekend. Bye-bye.
Bye-bye.
Excelente, muito bom, velho.